Good afternoon. My name is Kristen Haase, and I am coming to speak today on behalf of the International Society of Geriatric Oncology. Today, I'm going to be talking about aging, complexity, and the case for multidisciplinary geriatric oncology. My plan for my talk is to tell you a little bit about the older adult population and why their needs are distinct, to make the case for unique models of care that address these needs, and to describe models of care to address older adults' needs. So first, let's talk about aging and complexity. Cancer is increasingly a disease of aging, and complexity, not chronology or age alone, defines care needs. Geriatric oncology has emerged as a subfield to address this reality. And what do we mean when we talk about an aging population? This isn't exclusively a problem of North America. This is a global problem, a global challenge. And while those curves look slightly different in different regions of the world, this is known that the older adult population, those over the age of 60, is set to rise in the coming years. And with that means a growing number of cancer diagnosis in that population. So, what makes older adults different, and why do we need to pay specific attention to their needs? The big reason is heterogeneity. So, we have 70-year-olds who are climbing mountains, and we have 70-year-olds who are not able to get out of bed independently. This scale from fit to frail is one of the reasons in oncology that we need to pay attention. And it is probably also important to note that the folks in the middle who are sort of doing well at the moment may be living with underlying vulnerabilities. And that's perhaps the more tricky population and why we need to have different models of care to help support those folks. So, what does heterogeneity mean in the context of older people who have cancer? Well, first, it means that the decreasing life expectancy gives us a slightly different focus when we think about the benefits of treatments. As people change, their pharmacokinetics, the dynamics of how they process just general assaults to their system, including chemotherapy or systemic therapies, impacts their treatment tolerability. And because older adults are likely to have chronic conditions, most have more than one by the time that they're age 70, this impacts their treatment risks and it also impacts the treatment benefits. With increasing cognitive and functional impairment and increasing frailty, there's less evidence on how best to treat and care for older adults. And of course, there are also gender differences, noting that women tend to live longer and with higher rates of frailty as they age. So, aging and complexity are inseparable ideas. Multimorbidity, frailty, cognitive and functional vulnerability, those impact treatment decisions, and those treatment decisions affect independence, function, and quality of life. So focusing exclusively on the tumor when we're making decisions is insufficient. So what standard approaches get wrong compared to our older adult population? These assume physiologic reserve, so no frailty. They often typically have a single disease focus when our older adult population is known to be living with complexity and comorbidity, and they assume predictable treatment tolerance. Whereas geriatric issues and syndromes are often identified late, not proactively, managed reactively when a problem occurs, and these complex needs are often deprioritized in busy clinics. They're just not set up to manage the complex needs of older adults. One of the reasons that we see in the literature is due to ageism. Our systems are simply not set up for the complexity of older adults. Their needs are underassessed, they're under-referred to supportive care services, and they're often excluded from trials or intensive care pathways because of their complexity. So ageism is covertly embedded in our program design, our clinical pathways, our systems, and also our workforce training models, which assume this sort of healthy middle-aged person when we know that the majority of people who have cancer are older. So we need to think about care that goes beyond age-based decisions and focuses on function, cognition, goals, and social context. and shared decision making and coordinated team-based approaches that can address this complexity. And one of the key things that we need to address is frailty. And we need to think about frailty in a way that encapsulates both the physical and the social. The physical is something that we're more familiar with. And so these are reductions in strength, physical and physiological function, which makes people more vulnerable to disability and death. One thing that we are not as good at assessing and being aware of, perhaps we're aware of but not doing a great job of intervening on, is social frailty. As people age, their social networks tend to contract. This contraction of social networks can lead to an overall decline in mental health. This social frailty can actually lead to physiologic decline. This is something that we need to think about in the context of older adults with cancer. And I would also point to our recently released guideline on loneliness in older adults with cancer. So how do we identify frailty? Well, ASCO recommends that all older adults over the age of 65 receive geriatric assessment and guided management. And we know from the literature that this is beneficial to patients and those who undergo a geriatric assessment. It is associated with a lower risk of treatment toxicity, indicating that it has potential to optimize care treatment in this population. So this is important. So how are we doing? How are we doing this? Well, care is redesigned, and we think about first screening for frailty using one of the approved tools from the guideline, and then moving on to when individuals screen frail, moving on to geriatric assessment. So if there are vulnerabilities identified, they are then working with a multidisciplinary team to address these challenges, and the care is proactive and supportive. And you can see here on the right, these are some of the folks who might be involved in the trajectory when someone is receiving support from a geriatric oncology team. This is quite exhaustive, but probably not completely exhaustive. I don't see exercise physiologist on here, and that might be someone that we would involve as well. So care is more proactive rather than reactive. And these models really vary vastly by context, but share core principles. The reality is, unfortunately, that implementation of these programs is limited. These programs remain scarce globally, and many centers lack formal models. So some centers might have someone, a nice pathway to a geriatrician who's known, but by and large, these are not broadly implemented programs despite the guidelines. We also tend to see a reliance on informal or ad hoc approaches, which is better than nothing. And implementation gaps are a major barrier to equity for older adults with cancer. So, what are the implementation challenges? So, a lot of talk about implementation science these days, and it's pretty clear in geriatric oncology. One of the key challenges is related to the workforce. There is a limited access to geriatric specialists. Of course, there are always competing clinical demands. This is universal across all healthcare settings, and oncology is no different. And one of the key problems, I think, is that a one-size-fits-all model does not translate globally. It really doesn't even translate from city to city. So there needs to be a lot of flexibility. And I think the recent guideline on geriatric assessment, the global guideline, is really helpful for us to think about how we can be more flexible and be more nimble in implementing geriatric oncology and not sort of using excuses that we don't have the correct person or this really robust program. It also explicitly addresses mixed and low resource settings. It addresses the problem of workforce constraints and identifies feasible entry points for implementation based on the amount of resources that folks have in an individual setting. And you can see here on the table on the right, you can look at how we can implement different aspects of geriatric assessment based on basic, limited, and enhanced resource settings. So the key message from the global guideline is to really start with feasibility, start with screening before full assessment, and task sharing within teams, moving towards a more team-based care approach rather than a top-down physician-led approach. It emphasizes role flexibility, sustainability, and context-sensitive information. And I think what geriatric oncology as a subspecialty really emphasizes is the importance of multidisciplinarity. And so what has changed in clinical practice? In my opinion, we are moving more from ideal models to scalable solutions. There's more than enough work to go around, so there doesn't need to be a one-size-fits-all approach. This makes us moving from a specialist heavy models to team-based shared care approaches, centering the importance of work from nursing and allied health as central to delivery, and focusing on the global guidance really helps us to understand the importance of legitimizing pragmatic models and doing what works best in an individual setting. And I think as a final sort of thought from me, that multidisciplinary can help scale geriatric oncology. It's a shared response towards complexity. It integrates the principles of geriatrics into routine cancer care and reduces reliance on scarce specialists alone. So some concluding thoughts: aging and complexity demand team-based care. As I said, there's more than enough work for us to go around, so we don't need to worry about having sort of top-down cookie cutter solutions when there's really valuable resources across teams. The global guidance really supports this flexible implementation approach. And I would argue that multidisciplinary teams, those that involve nurses and allied health and folks across the continuum with different types of specialties, is how geriatric oncology will flourish across settings. Thank you very much for your time today. I look forward to having your questions.